everybody. We are here for the ladies webinar series, and today we're going to be discussing just all things associates. And for some, this may be some of the first things you've heard about or the first time you're thinking about it. For others, this may be, just a good refresher of things to remember. When do you need associates, how to find them, how to retain them, benefit packages to be offered. I know that I'm in other, mastermind type groups that this tends to be a pretty hot topic about what people are talking about percentages wise and benefit packages and when do you even need them in the first place. So I would love to introduce some amazing women that have done it themselves. I know them personally and adore them both. They both have fantastic flipping practices. So I'm going to start with Kelly Dove. Tell us a little bit, you've joined me before on this, so people know about you a little bit, but tell us a little bit about where you are, a little refresher on what's going on in your world.
Yeah, absolutely. Thanks for doing this, Summer. It's great. So I am a general dentist and I'm a husband and wife practice, and we have two offices, one that's a 4-operatory office and one that is an 8-operatory office. And so since we're talking about associates, we have associates at both offices, and my husband shares his time between the two offices and I stay mainly in the large office. So we've got a little bit different experiences with the associates and onboarding, and I'm excited to share a little bit more with that today because it's been a fun journey. And we've learned a lot over the past couple of years with onboarding the associates. So.
Yeah, oh, absolutely. I love what you have to give. I was just talking to you at our last mastermind meeting about your experience with associates versus Steve, your husband, his kind of perspective. It's so interesting, and I truly think listeners are going to love to hear about that. So thank you for joining us. Charlie, tell us about you.
Yeah, so I have a practice, a 4-op practice that when I purchased it 2 years ago, it came with a semi-associate. He was already working and I was working in there, and I bought it from a doctor who owned it that never worked in there. And he kind of hung around for a while knowing that he didn't want to stay there forever. He wanted to go do his own thing, but stayed a lot longer than I thought. And then found a different associate in there because of maternity leave for me. And now I have another associate in now. And my story really is that I have never, since I've had the practice, worked it full 4 days or 5 days a week. I've always had someone else with me. So I don't know that I know much different than that in my office, but so far it's worked out well. And I've had in total 3 different associates.
Awesome. And then, of course, we're going to pull Ashley in because I always love Ashley's perspective. She knows all 3 of us very well. But what I love is because of affiliation with Mark, with DSI, with DSN, she gets to hear a lot of what we don't get to hear from the other side often, things that she sees go well for doctors and things that don't. Because I believe, too, she's been really invested in other offices of Mark's as well. And so she knows exceptionally, even probably better than us in some aspects of when associates can go really wrong. So I really value her opinion in this as well. So,
thanks, Summer.
Yeah, of course. Well, the first thing that I'm going to ask is, how did you know when you thought it would be a good time to get an associate? Carly, you kind of answered that. Yours came with that associate, but when did you know it was a good time, or did it just feel right? I just want listeners to hear what you did, and then we can discuss kind of when, probably from a metric standpoint, is the right timing. Go ahead, Kelly.
Yeah, so, Kelly, go. No.
Me to go? Okay, cool.
Yeah, go, Kelly.
Well, okay, great. So 2 different experiences with the 2 offices, which, so the first office, it was a smaller office and my husband was mainly in that. He was the main doctor and I was getting ready to have a baby. And so we both knew that we wanted to kind of pull back from our clinical days, and we wanted to see what that would do with the team in the office to hire an associate and kind of switch my husband almost out of that office and onboard an associate. So that was the original office. That associate has stayed, it's going to be almost 3 years. And we had really built up the team culture and the strength of the team a lot to be able to transition him and to have Steve almost completely walk away from the office. And so that was an interesting, unique situation, because not a lot of people just plug an associate in and almost walk away from it, which was a whole nother income adjustment for us too, because obviously now we were living off of the profits of that office, not the income of the production of the office necessarily. So the other office, we actually just added a doctor to it. So I stayed in there full time, and we just added him as a production doctor. And that was right before the pandemic, actually. So we onboarded him in like December, and I shared new patients. Our metrics for that was we were looking at the new patients, and we had the extra operatories in the office. So it was something we kind of always planned on. We were just waiting for the right time. And as you know, we're going to talk about recruiting. Sometimes things fall in your lap. Sometimes they take a while to recruit the associate doctors. So it seemed to work out. The timing worked out for us, and the new patients and the numbers were certainly there in the office to onboard the associate. So
awesome. And Carly, you know, like you said, you came with one. You know, you bought that with that associate. But how did you know, or how did you figure out when to add, you know, another one? What did that look like for you?
Yeah, so I kind of out of necessity, because I was pregnant and I knew I wanted to take some time off right after having her. So I knew the doctor that I had working with me, he also had other things going on. So he was only able to do 1 or 2 days a week if I went on maternity leave. So I thought it was important to have someone else so we can still be running a full-time office. So I definitely looked. I looked probably right from when I first was pregnant and worked on finding somebody, and it worked out really well. And he was, I mean, to give you some story on that, he was going to partner with another doctor in town who's actually a part of DSI. And he was kind of like, hey, I've got this doctor. I'm not going to be able to keep him busy right away. He could help you through maternity leave. So it ended up really working well, us sharing him for over a year, I guess a year and a half is what we kept him for. And then ended up just the partnership with them worked out. And that's when I found the other doctor, because I realized in that I really like doing clinical dentistry 2 to 3 days a week, and managing the office as well as spending time with my daughter. And that's what led me to find my third one, who just started like 2.5 weeks ago.
Yeah, awesome.
awesome.
Yeah,
Great.
Yeah.
Well, and it's funny because Kelly, by the way, when you were telling me the story of that first office where you didn't have metrics, it was kind of like, well, we built up the culture and Steve needs to take some time off, and you just kind of plugged in. That was very similar to my story, which was, you know, I had to get an associate in due to truly becoming physically disabled. I had to just throw somebody in. And I tell people that, you know, God bless America, it worked. But obviously we all know now that there's certain metrics that you can actually start looking for to recognize if you actually are ready for another, you know, are ready for your first associate. And, you know, one thing that I think all three of us would probably tell doctors is, one, look at your periodic exam count. And truly figure out if there are so many periodic exams, which, by the way, that starts to happen usually with about 2 hygienists, depending on their level of perio and new patient exams. But if you're starting to hit more that 120 to 150, as Jake likes to tell us, you know, if you are hitting somewhere in that count for periodic exams, you're probably starting to do more exams and less time doing clinical dentistry. So your production may become stagnant or stale, or you're going to be running around with a lot of chairs but not seeing any production get higher. That can be one kind of, you know, indicator. The other thing is, you know, we all know too that if you start to see that your hygienists are producing in a general practice, that are doing mostly bread and butter dentistry, if you're starting to see that metric is for hygienists getting above 30%, 29, 30 and above percent, I've seen it as high as hygienists producing 40% of the practice. That just means we're not producing enough true clinical dentistry. And that doesn't mean necessarily immediately get an associate, but what it does mean is something may be a little bit off. If the hygienists are actually producing that much of the practice's production, is it there's not enough doctor hours available? Is it that they're doing too many exams, as we've discussed? Is it, that when they're in the chair trying to do dentistry, they're getting pulled into all those exams, and so they can't do high value dentistry? Those are the things that we start to look at metric wise. Kelly, you and I kind of threw somebody in and it worked, but we can both say there's really smart ways of, like you were saying, looking at new patient numbers, new patient flow, looking at how much attrition you have in the practice. If people are leaving as fast as you're getting them in and you're not growing, that can be an indicator that something's off. You may need some help there. And then, like I said, periodic numbers, check to see 120 to 150 periodic exams is about all, most doctors can do and still produce really great dentistry. And if your hygienists are producing over 30% of the practice in a general GP practice, we may be getting to that tipping point. Sometimes I see, I don't know about you guys, but doctors will often tell me, well, I'm just super, super busy and I'm booked out 3 weeks. Well, I don't know what you guys' feeling is on that, but that's not always the only indicator that you need help. You actually have to be able to pull some of those other statistics out and figure out, is it that you're just being super busy and not, or that truly you're to that tipping point by using those other metrics. So I don't know if you guys have anything else to add there. I was just thinking to myself, like, how I did it, I don't think I would probably always suggest other people do it like I did it. I think that there's some really good, valid ways of knowing that it makes sense of when you need an associate. But is there anything else you guys have with that besides kind of what we discussed, hygiene, periodic exams, true productivity of the days versus busyness? Anything else you guys have?
Yeah, I just want to tack on to that. So I, of course, haven't actually worked as a dentist in a dentist office, but when I was partners in one in Phoenix, our main provider there, we were looking to bring on an associate, but he didn't think we needed one. But one, he was too busy and booked out 3 weeks, but that too busyness wasn't necessarily, production, like profitable production. And actually, it was getting to the point of concern that things were being missed on the patient's behalf, right? So I just kind of want to tack back on to how important it is with that number of periodic exams, because if you're just doing a ton of them, it's possible that you're missing stuff and not even delivering the level of care that the patients might need just because you're too busy and too swamped to be focusing at your best, and then two, really looking at that, what does that busy look like and booked out? Like, you might be booked out, but what are you booked out with?
Absolutely.
Right.
It's funny because Mark and I've talked about that like I can remember times where, because I had 3 hygienists at one point, where I can remember I would actually hope that there wasn't work that needed to be done when I went into those exams. That's a bad sign.
Yeah.
Thinking to yourself, how quickly can I get this done? And I hope there's nothing. Wow, that may mean that you're just many. So yeah, good point. Go ahead, Carly.
Yeah. I was going to say, I think it's really like about efficiencies in the office. And it's like, well, do you need to add another assistant maybe to take up some of that time that's not productive, busy time in the office? But it's also figuring out the right amount of doctor days. So like, I count my associate and myself kind of as one doctor, since we're there 4 days a week and it's every other day for us. And so we're getting to that point of recall exams. So now we look at it and we say, okay, well, John, now you're going to do Fridays because we need more doctor time. So it's kind of you can only do so many doctor days. So I feel like you really have to, as a provider, decide how much clinical time you want to give and how you can find the help, whether it be you need another assistant, another hygienist, you just need to make systems better in the schedule, or you do need to bring on an associate. So I feel like it's really about looking at everything together.
Absolutely. Absolutely. Well, and one thing, go ahead, Kelly, go ahead, please.
Oh, Nathan, I felt very committed when we added the doctor to the larger office to make sure that it was going to be successful, because I think it's almost a little bit easier to put a doctor in an office that has a really solid structure and core with the team members, because they can pretty much just point him in the direction and say, or him or her, go here and do this, and he just kind of, or she follows the little the little bowling bumpers, if that makes sense. Whereas the other office, those, even though the office was busy or there were a lot of new patients and the patients were all there, it does take a little bit of time or growing pains for the office to get up to that full capacity of being able to add an entire doctor. It's a little easier to do it like Carly said, doctor days. And Steve and I kind of did that because technically we have 9 doctor days in that office, even though one doctor works 4 days, one doctor works 3, one works 2. You really do need to look at it doctor days. And we were kind of able to pull back between Steve and I a few of those doctor days to give him the volume to get the practice to grow to the level that we could get it to the full 9 doctor days. So it wasn't an immediate jump for us anyways, immediately. So there's a little bit of a growing pains when you add a full 4-day-a-week doctor.
Such a great point, Kelly. And actually that piggybacks so beautifully with what I was going to say, which was, you know, we all know that, all 4 of us know that, you know, making sure before we bring that associate on, systems are tight, systems, culture like that are as fantastic as possible. But that includes maintaining overhead under preferably at 55% or so. That's so important when you bring other doctors on, because Kelly, your point in the very beginning of Steve and you kind of took a hit financially, right? When you, so did I, because I didn't have numbers really solid before she came in, because I had to just kind of throw her in. And if I would have spent more time having those numbers more solid, it just wouldn't have been quite so financially tough at the beginning. So I love this discussion of really just even when do you know you need an associate? It's a little bit, there's a little bit more to look at than just, am I busy? Do I feel, you know, I think we've kind of said that's not necessarily the indicator. That just means it's time to look deeper into all the different things that we just discussed. So
that's a symptom, right?
Yep, absolutely. Yeah, if you're that busy and you're booked out so far, it's time to look at more why, and is it more efficiencies, systems? Not that you shouldn't get an associate, but really looking at some of those metrics first. And, you know, please message us if you need somebody to help you kind of look and dig deeper into some of those metrics, because that's really what you need, is somebody to help you understand those metrics first before you add that associate if possible. So really, that was really great. Thank you guys for that. So, you know, where do you guys tell people to find associates, and what are some of your tips and tricks? Ashley, you can absolutely, you know, chime in here too, because you've seen a lot of associates of Mark's and things like that over the years. But where do you guys look? What do you find are good tips and tricks that you give other people for finding them? Carly, do you have?
Well, so I just thought of a really good story based on this. So, well, my success through finding good associates has been through the network of people that I know, has consistently, that's been with most of my hires, honestly. But I did, so when I was going on maternity leave, I had an ad and I didn't get very many quality applicants. I got one guy who was very eager, and it was right before a mastermind event. And he said he knew Mark Costas. So I asked Mark about him, and he kind of sort of remembered him. And he's like, let me ask Ashley. Ashley will know. So I don't know if you remember this, Ashley, but I don't think you were there at the event, but he called you and he told you the name, and you were like, and I was like, thank you. Cause I was like literally trying to like figure out his malpractice insurance so he could come and do a working day with me. Like, he seemed a little quirky, but I was like, I don't have anything. I'm going to just give him a working interview day and see. But I was like, I trust Ashley. If Ashley tells me that he was no good, I'm done. So I really honestly, like, my biggest success is like talking to people, networking, and knowing who you're signing up to work with all the time.
Yeah.
Kelly?
So that's so funny. So, you know, kind of like Carly, we got a little lucky with our first one. He was actually a colleague from dental school. We had known him. We weren't in the same class. Both of our associates have come out of Medicaid offices, which is a whole nother topic for another question, because that was a little bit challenging onboarding for private practice. However, they're both excellent doctors. And so one was a friend and the other we recruited with an online video. So we were able to post a video to Indeed. And it was not a fancy, like polished, we paid a lot of money video. It literally was Steve walking around the office with an iPhone and just being really candid about like who we were, what the office looked like, these are our faces. And I think it gave that personal touch so that it wasn't just an ad, somebody flipping through it. And it was enough for us to get a really good candidate in. So he's worked out really well.
Awesome. That's great. Well, and I think for me, my very first one, Kelly, exactly like yours and Carly's, was networking. Networking and coming to find out she was somebody that I actually knew through my dental school and things like that. And so, but I think networking is such a fantastic way. And, you know, DSN is such a beautiful platform as well. I feel like, Carly, you posted something about, you know, a friend moving to Dallas or something like that. And I was like, isn't this so cool? Networking. The other thing that I tell doctors is, you know, when you're ready to place an ad, place the ad built on a very specific avatar of doctor you're looking for. Sometimes I find that we just spray shot stuff out, much like we would sometimes an ad for anything else, you know, or we say like really ambiguous general terms like hardworking, ethical, high integrity doctor. Well, everyone's going to read that and say that's me, probably. I know, I can't imagine a rare doctor being like, that's not me, I don't think I'll answer. So I do tell people that, you know, think about what do you need in the office. And if you don't do endo and you never do surgery, maybe a good avatar would be, hey, I am looking for, you know, and I help doctors often like think through, like, truly, what are you looking for? Who is that person? Where do they hang out? What do they do? You know, what do they think about? What do they read? That's what you want to write that ad for. So write the ad for what you actually need in the practice versus spray shotting. Because if you don't need somebody who, you know, does a ton of pedo because you love pedo, you know, that's probably somebody that you could easily exclude and find more of a target of who you want. And, you know, people laugh and are like, well, does that really work? My last associate, I placed an ad for endo implants. I did not get a ton, but every one of them fulfilled that qualification. So the ones that I had to look for were exactly endo implant doctors. And so I would tell people to, at least when you're writing that ad, start with what you want and who those people are. And then where to place them, I think we can all agree. Indeed, I love that video ad, Kelly. That was such a beautiful, I
actually just wrote that down. I'm like, that's brilliant.
So, appeal to that specific avatar with a video on Indeed. I know for me, like the local dental association of Colorado is a place that I, you know, place the ads. In networking, of course. Any place else that you guys have found is really helpful for recruiting actual doctors if you're going to place an ad?
There's actually a few, so it's hard. This is a little challenging, of course, because sometimes, you know, you're not necessarily looking for a brand new grad because that can be a big time investment. Sometimes that can be super helpful because then you can mold them into exactly what you want them to be for your office. You don't have to necessarily break bad habits. But different dental schools in your areas often have job boards as well. And that's somewhere that we've had some success with as well. And just taking a look at I Hire Dental is another one, and Dental Post is one that we've posted on recently too. Dental Town also has a board that doesn't cost a ton. You know, be careful though, I would say, with regards to your ad spend. You know, if you like invest in it once for the month, and if you're looking into next month and you've gotten nothing off of that board, you know, you don't necessarily have to keep going with it. Of course, Indeed is the monster, man. And Indeed that is what it does. So it's a pretty good resource, but that's been my experiences. There's a couple specialized ones, especially if there's a dental school in your area, or, you know, dental schools in any dental school, you know, because dentists, I mean, you guys can, I'm sure can relate that after dental school, you are going to move all over the place. So it doesn't necessarily have to be in your area. And it's not like just because you're in the San Francisco area, those dentists are going to want to stay in that area. So.
Absolutely. Yeah, dental schools. And then I tell people GPR. So residency programs, often you can actually contact the school. So if you're looking for somebody that's not quite fresh out, but it's still pretty moldable, I'm like GPRs, especially there's GPRs that are, you know, more endo heavy, more surgery heavy. I recruited one a couple of years ago from a GPR program that was surgery heavy. And so he did IV sedation, a lot of surgeries, but didn't have yet that general, you know, practice experience. So you're right, kind of moldable and things like that, which are great. So good tips for sure there. The one thing I do want to touch on, which, you know, I think Kelly, you kind of brought up too, is, you know, sometimes recruiting from Medicaid offices, or like I too recruited from kind of like a care clinic. Tell everybody a little bit about great things, you know, obviously with these doctors. What were some of the concerns that, you know, maybe came right when you had that person come in?
Yeah, absolutely. So, I mean, they're both excellent doctors. I will say the model that they came from was different than the model of general practice. And so basically, they had spent, one of them had spent 4 years and one of them had spent 8 years in a model where you basically went in, you diagnosed what needed to be done, and the patient really didn't have any obligation to pay for that work. And so it was just presented and scheduled. The biggest challenge for them was getting the patient to show back up for their appointment. And so going from that type of model where it's paid for and they just have to show up to their appointment, versus going to a general practice model, which you have to diagnose, work out finances, and oftentimes sell things to people that they want. So listening to what the patient exactly wants and transcribing that to a treatment plan that matches the health and the benefit, and sometimes what the patient might not even need, if that makes sense. Like, so if they want veneers, you know, that's a different patient. We all know that in general practice. So getting them to be on board with relating to the patient better, to communicating with the patient, and to diagnosing to a different level than they had previously done, that took some time for both of them. One has had a quicker learning curve than the other, I will say. And so it just takes a lot of one-on-one follow-up, checking treatment plans, and following up on case acceptance too, because I do notice, and I think it's very common, that the associates production per patient is lower than the owner doctor's production per patient. And so that is something that I'm really keeping a tally on and making sure that we're following up and that treatment plans are going the way they need to be going. So.
Such a good point. So for doctors that are looking for associates, they get those applications and they see, you know, in my case, I had one that was at a care clinic. You've had Medicaid, you know, doctors. That is such a brilliant point of, it's not necessarily to say, you know, they're not going to be acceptable. It's just knowing that learning could be a little bit higher for them, and, you know, maybe get a little bit more instruction and help and mentorship in private practice treatment planning.
Yes, absolutely. And the way we've found to offset that is by having really strong assistants or team members that communicate with the treatment plan presentations. So at the beginning, that has been a very key factor, is making sure that they have the right support system in the office, or at least an alert system to come and alert us. Like, hey, they aren't quite treatment planning the way you treatment plan. And so that helps us go back to the doctors and say, okay, this is how we've got to do this. And obviously we missed the mark here. Patient called back and said, well, I called for a toothache and that didn't get addressed. I got all of this stuff planned. So it takes some follow-up work to do, just to kind of break some old habits.
Yeah, absolutely. Because I experienced, by the way, Kelly, exactly the same thing. She was a great doctor. I love her to pieces, but she had a really hard time for all the exact same reasons you stated as well. And, you know, Ashley, you kind of touched on, getting a new doctor versus, say, a seasoned doctor. And what's cool is we have all of it right here as to the different, people's perspective on that. And I've had both, brand new, literally right out of school, and I've had seasoned. For me, what I tell doctors is, recognizing, yes, new doctors don't come with any habits. You may not see a return on investment quite so quickly. It's going to take longer, and you have to be available for mentorship quite a bit more. I couldn't just throw her in office and talk to her once a week at lunch. You have to have somebody there that can truly be readily available consistently for them. And in addition, much like Kelly said, incredibly strong team. You have to have people around those new doctors that make that doctor look good. But then I've also had the experienced ones, and much to Ashley's credit, like you were saying, they come with some really difficult habits and, kind of a sense of almost like, I already know what I'm doing, which
and they don't want to be coached.
They don't want to be coached at all, which, by the way, is something that I tell doctors all the time, especially females, which Kelly, you and I were talking about at our last mastermind event. Female doctors who, Carly, you can speak on this, have a male doctor that has the same number of years or even more. What I find is they tend to back off often the owner doctor, especially if they're females, and be like, well, they already know what they're doing. And often that leads to lots of resentment, lots of frustration, I have found. If really those expectations weren't stated from the very beginning of that, for that experienced doctor, if that wasn't discussed ahead of time, oh boy, can it lead to some bad feelings. So I can see a lot of people shaking their heads. So Kelly or Carly, what has been your experience with that?
I mean, I think I've been really fortunate with the doctors that I've had, that they are associates. It seems like they've chosen that for a reason, that they don't necessarily love the business side of it, and that they kind of are looking for a little guidance. So two of the doctors I've had more experience than me. One I was super lucky with because he went to my same school, so we had similar training, so there wasn't really a whole lot that I had to do, but they've all been very open. And I think, like what you said, expectations, just knowing that, like, I am going to be checking in. We do have certain ways we do things. So now my current doctor, who I'm going through training, right, or mentoring right now, I kind of have been learning a lot, because the last two I didn't need to do a whole lot, but they still were very respectful when I did have my input. But it was like, once a week check-ins, and things are good, no complaints, we're good. But now this one, he's less than 2 years out. He was in an office by himself before this. Like, he's good, but he still is very green. And I've realized I need to be in there, like, a lot of the time, and be giving him extra guidance. I even have him, since he's not full time and he doesn't have another job, he comes in on my days too, to see how we do things. And he's been so receptive and so grateful to be exposed to this, because he's never seen how a nice private practice runs and how teamwork and systems really make a difference. So I think it goes back to just picking the right fit for your office and personality and culture, that you can kind of harness however they fit within that team, and being able to have open communication. So, it starts with getting the right personality in there.
Absolutely, which kind of just a little bit, what personality tests or things like that. Because I know too, Kelly, kind of big on those as well. Tell us a little bit about kind of your experience with what this topic is. With having the male doctors.
For male doctors. Oh, that's so funny, because after our discussion, I was in a room, and we were at like a social function, and somebody came over, and we were introducing ourselves. And I have a doctor he's old, he's practiced longer than me, and male doctor. And that's what Summer and I were discussing, this situation. And so when the introductions were going on, I was basically like, and this is my colleague, Dr. John. And then he laughed and said, "This is my boss." And so I think that was an aha moment for me to realize that's okay. Like, I don't need to feel awkward about that. And that's probably a lie that I have told myself, is I can't manage a male doctor that is older than me, or this is awkward, because it probably is more awkward for me than it is for him. Because obviously if he's comfortable in a group setting to be like, this is my boss, then he's okay with it elsewise. So I think the personality of our associates matches that just fine. I think if I had like a really strong alpha male in the office, I don't think that probably would pan out well for me being the boss. And there's nothing wrong with that, but I think a lot of the times, like Carly mentioned, there's a reason that they want to be an associate, and there's a host of reasons if they don't want to manage the office, or if they just want the freedom and stuff. And I think most of those alpha males are going to be the ones that go out and start their own office and realize that from the beginning that they don't want to work for a woman. And so I think that problem that was kind of an internal fear of mine is kind of working itself out a little bit. And I love how, Summer, you talked about having your avatar for a doctor, because mine was probably a little illegal. I really wanted a female doctor because that was that was a fear
A
of
little
mine.
illegal.
Yeah, I know, but I hired a man, so it's okay. Like, right? I mean, like, we picked the best candidate out there. So, but that is something that was just an internal fear of mine, and I really had to get over that, because there's nothing wrong with managing men in the office. And some, you're going to have to do it a little bit more like your husband, when you make sure that it's their idea versus your idea and you telling them what to do. I mean, that's something that women are skilled at, so that I'm reflecting on how exactly I approach different things. And oftentimes I find that people respond better when they think it's their idea versus my idea. And so that's a little bit another one of my sneaky ways of managing men. Or I put Steve on it. If it's super difficult, I'm just like, hey, you're gonna have to go take care of this.
I kind of just want to tack onto that too. And I think that's absolutely, and it's skill set, and it's like the kind of the joke is that I word ninja things, right? Like we just word ninja things to, say things specifically. And I want to go back to too, how important it is. And for any position, right? Like I hire for a ton of positions, and for any position, just to set the expectation from the beginning, like, hey, and maybe in an instance where you might feel uncomfortable saying, hey, by the way, we're going to be checking in on your work every single week and seeing if it matches what I would do. Maybe it's more along the lines of like, hey, every week we like to get together to compare treatment and just make sure we're on the same page. We want to be delivering the same level of care. We want to be, we just want to be sure that we're providing the best treatment we can to our patients. And I am always open to different suggestions on how you might treatment plan something different. And I would hope that someone in this position would be open to the same feedback, so it's just about setting those expectations from the beginning, no matter what position they're in, and letting them know, like, we're going to be checking up on you, basically.
Yeah, and that's how I feel too, because I have them from all different levels at this point, and they're all working amongst each other. And every time I feel like every time with every associate, I learn that setting those expectations even clearer than it's like over communicating. I don't want to micromanage, but I do want to ensure that we're giving that level of care to all patients. And I need you to know that when it feels like I might be micromanaging, I'm only going to do this until, we've really worn that path, that we have that amount of trust with each other. Once we have that amount of trust and it's been proven over and over, I won't feel probably quite this need, but, to check up on these things. But until then, I do the exact same thing, Ashley, where it's every week, I am going to look at post-op x-rays with you. I am going to look at your KPI sheet, because all of my doctors track their KPIs in a spreadsheet, so they all see each other's. And I tell them, and that's one of the expectations I set, that, hey guys, this isn't for competition. This is truly to see, Dr. Mel is killing it here. I'm having a harder time, that's the doctor I'm going to go to. So I try to, set the expectation of, we have built-in, mentorship in every department you could possibly think of. Your growth, though, is up to you, doctor. So expect that this is going to happen, but then when it's ready to learn and grow, here's your part of what you can do to make that happen. The resources are there, but here's what you need to do to be able to grow. So I think that male, female, a younger doctor, a Medicaid doctor, it doesn't matter. I think what we're all trying to say is it really does come down to setting as clear as possible expectations, which, that leads into a great question of, what do you guys feel like maybe you've done super well with onboarding, and what maybe you wish you would have done better, or the next time you think you would do better? Whoever wants to chime in first, go ahead.
I like to find out what motivates the doctor. We talked about that at the last mastermind. Everyone has a very different motivating factor, and having them self-reflect a little bit on it and actually come up with their true motivation, it really helps set the stage for their expectations of the office. I also like to know their salary expectations, because we kind of believe in the philosophy of you eat what you kill in the office. We pay on collections, and we don't have like a super strong benefit package that, say, like a corporate type facility would. And so it really is an eat what you kill in the office type model. And so I want to know what their salary expectations are, because I want to know if they're realistic or if they aren't realistic. And I like them to be happy with their job too. So if their salary expectations, if one of them said, well, I don't have one, I just want as high as I want. And that's a concerning factor to me, because at what point will you be happy, or will you constantly be searching for something? So the longevity of that doctor might not be as long. The other thing I like to do with onboarding is, with their salary expectations, I like to walk them through what their realistic production numbers need to be on a daily basis to get to their salary production. So you just work it backwards. It's really easy. So say they want to make $250 a year, then we've got to calculate how many days you need to work and what production you need to make per those days to be able to hit that salary expectation, so that we can support them in a way that they're able to achieve that goal. And it's also a red flag if I know we aren't getting anywhere close to that salary expectation. That might be a determining factor to them not staying as long as we would like them to do. So yes, Summer, I love your ideas with going over the cases, following up on post-op bite wings, especially with new grads with interproximal fillings or multiples, really checking up and making sure their cases are going well and strong. I also watch Google reviews too. I like to be reassured that the patients are liking them enough to get on and write Google reviews, and that we aren't consistently getting any negative feedback from those doctors. So those are all big portions that I like to have realistic expectations, just to make sure that we're going to have a good fit moving forward before we really get married in the practice.
Absolutely. Yes. This webinar is not long enough to go into the marriage partnership thing. That'll be the next one, Ashley, after this. How do you know all things partnership, right? But yeah. Carly, what about you? What do you feel like you've done really well? And now that you're doing it like right now as we speak, yeah. What do you wish maybe you could have done, if you have anything?
Yeah, so I think my biggest challenge with this new doctor being onboarded was the team buy-in. I think I did a good job. So he was coming from out of state, and when he would come to visit, he would like come to our weekly meetings. Some of them were around the holidays, and we'd play a game with him, and we do fun like culture type things with him. But I didn't maybe prepare my team enough with the way he's going to work clinically. I got lucky with my other doctors, where one went to the same school as me. We kind of just did things the same way. So I wish I almost would have done like a real working interview with him, so we could see how he does things. And now I am definitely like, in the mornings before we walk through a procedure, we do it, we role play with the assistants, but I wish I would have had the chance to do that a little bit more before he was actually in there working, because the team probably, and most people who are watching this, the team that they've built, they support what you do as the doctor, and they're like, Dr. Casmo, how you do this is the right way. Dr. Dove, that's the right way, and that's the only way. So when they see someone else coming in and doing something different, to let them be open to that and helping them. And I know that they also realize they're working with a doctor, and they can't, the same things I would say to them aren't taken the same way from the team. So it really is a whole office approach with integrating a doctor in. So I think from the culture side of how we do things, I did a good job. Like his first day was the day we did our quarterly calibration meeting. So like, I think that was a really good thing I did, but I definitely think next time I will have more hands-on with how we actually are clinically working through things for the team.
That is so good. All of that, I'm just like, so good. That's so brilliant. What's funny is I had, when I was thinking through it, like as you guys were speaking, like that all resonated with me so strongly of things that I feel like I've done well and things that I haven't. And I even remember a long time ago when I was an associate, Carly, he didn't set me up well. That team annihilated me. Like that's not how he does things. They made me feel like, it's funny, Kelly, because they want a strong team that can kind of help keep them in the guardrails, but still let themselves. This team, guardrails, they kind of smashed me down to where I was like, okay, I'll just do if you want to do that, because no doctor feels respected when they're treated like that. So it is such an interesting dichotomy of prepping them to know that they'll do things differently and being able to communicate respectively to that doctor. Being able to set that culture up like that is such a great point of, we want to do things similarly, but just like two DAs are not going to do things exactly the same, two doctors may not be exactly the same. So such a beautiful point between all of that you guys made. And yes, I love that. The one thing that was very similar that I think has worked well, the more I've honed it, Kelly, is helping doctors understand, just like you said, you are in complete control over what you make. You may think that it's what I feed you, but really everything you need is right in front of you. And so we do the exact same exercise of, you want to make how much money in how many days? How much time do you want off? Because then we just reverse engineer it, and that's your daily goal. And they come up with their daily goal. Really, if you think about it, it's almost like if you want to make this much, that's your daily goal. The second part of that is, like I said, setting up the KPIs, because my goal is always, I want you to learn how to fish, doctors. I don't want to have to feed you fish. I genuinely want you to look at those KPIs and say, if I tweak this, then this will happen. If I do this, then this will happen. If my exams I have 120, but I'm only treatment planning 300 per exam, it means I've set myself up for a worse next month. I love them to start to get those light bulb moments of like, oh, wait, I'm in complete control of this. And when they start to see, such a success story, my last doctor, she literally was 6 months out of school, and to watch her numbers ramp up so quickly, so fast, wow. And it wasn't because I did anything awesome. It was because she understood, if I do this, then I get this. So I think that's such a beautiful point, Kelly, of helping them take truly ownership and control makes them feel empowered. Ashley, anything that you've noticed for onboarding that works really, from everything we said too, that works really well, and things that maybe we've left out that don't work well?
I mean, you guys have covered I think incredible, and that's what I would say as well. The only thing I could add is that if you assume that, never assume anything is common sense, never assume anything unspoken, they assume, say it out loud. If it's your expectation, put it in writing, put it, out there. So, so that there is no question. If you're like, oh no, they would totally know to do that. No, don't assume that. So that's, I think, the biggest thing when it comes to onboarding is just remember that common sense is not common in any position. And just keeping that in mind and setting your expectations and verbalizing them or writing it down. Like you can't just expect them to know what you expect.
Yeah.
Yeah,
I
so
just thought of something else too, because a lot of times associates don't know how much things cost. We play like a little game in the office of how much does this cost during our office meetings. And I mean, I like randomly go back and grab something like Fuji cement, or I mean, really, like I just randomly go through the shelves and grab something. You know, even composite instruments, like, you know, I mean, when they get all gunked up, or the paladin ring, or, you know, like there's so many things that when you're like, that costs that much. And so, I mean, I hold it up and I'm like, okay, guys, how much does this cost? And they go through, and I'm always amazed at how the team is like, oh, that costs $150. And so it gets a little bit more buy-in. You know, I think associates tend to not be as cautious unless they're educated about how much things do cost in the office. So, you know, we base our team based on our overhead or a bonus and everything, but the associates really is on their collection. So, but I do like to kind of educate them on how much things actually do cost, because especially if they're a new grad, they don't have a clue. So
I love that so much, actually, Kelly. Like, you're right. If they've never owned necessarily anything, they don't know. And you know, I have my doctors actually, if they want to switch to something, or if they want to do something new,
yes.
they have to research it and bring it to me with the cost associated, so they can see it. But what I have found is sometimes that doesn't even actually resonate necessarily either, because what's $1,200 to them, you know what I mean? Sometimes it doesn't resonate. But yet, at least if they have an understanding of that, I think it's so important. Hey, one thing that I know people are going to want to know, guys, from everyone, and Ashley, you can kind of chime in too. What do you guys find in your area is the benefit package and how you pay associates? Collections, production, kind of go through and tell everybody either yours or just kind of generalization in your area.
I can start. So it was actually somewhat of a joint effort between the two of us how we did it. So it is on collections in the office, and we also subtract 30% of his lab fees out of that. And then he's on a tiered production based on what he produces. So anywhere from 27 to 33% based on what his average daily collections are.
Awesome.
And then benefits, yeah, I don't really offer any fancy corporate benefits. I started a 401k plan. He hasn't been here long enough now in the office to be part of that, but that will be something that's offered to him. And then I do pay a little bit for CE, or I would pay if it was like a group, like we used to pre-pandemic go to a lot of like courses together as a team. So if that starts up again, that would be available to him.
Great.
Awesome.
I practice in rural Missouri, so sometimes I feel like it's comparing apples to oranges. So I probably have a little bit harder time recruiting doctors. However, from me working as an associate and reviewing contracts and then talking to other colleagues in the area, I think I'm pretty competitive for it. It seems to be pretty standard. So it's a set percentage of collections, similar to Carly. Both of them pay a percentage of their lab fees just so they have a little bit of buy-in. We actually share our in-office membership club, so they get a percentage of that, because I want there to be some motivation for them to share, to try to present that to patients and everything. So basically it would be like them getting paid for the exam of the membership plan. So that kind of honestly almost offsets the lab fees every month. So they pretty much get the flat collections. And then we cover CE and malpractice insurance through a certain amount. So yeah.
Yeah, and I would say, you know, I live obviously up by Vail, Colorado, and so I do 30% net production. I do 3,500 for CE. They get some sick time, malpractice, and we too are, we have the Q-SARA for healthcare, but we're looking at actual true medical policies. One thing that I tell people too is if you're having a hard time recruiting doctors, sometimes look at what you can give that corporate doesn't even think about. And that's things like I paid for a year of childcare for that new doctor because she has 2 little kids. It's hard to find childcare. So I actually paid for that in lieu of something she didn't need as much. So sometimes a nanny or childcare or, HSA type things that maybe other corporate offices don't necessarily offer. I've even said like a cleaning lady for 6 months to help just keep their house, up to speed because they have a husband that works and 2 little kids. And even somebody to actually, like a nanny who actually just takes their kids back and forth to different things. There's so many things that if you get to the true motivation, kind of like you were saying, Kelly, of like, what do they need? Sometimes, when they look at the benefit package of corporate, that's what's normal. Sometimes when you give something that's not normal, it's actually perceived of higher value when the value wasn't even monetarily higher. Like that childcare was $2,000 for the year. That's actually less than one of the other things that she was like, I don't really need that because my husband has it. So I said, great, what if we do this instead? She was over the moon excited to have that because nobody else would even think of offering her childcare instead.
So Summer, I have a question for you on that. Like, how do you tag that in the business or do you just pay that yourself? Maybe that's me being nosy. I'm sorry.
Yeah, please. No,
kind of.
Fantastic. This is for us too. So accountant and your bookkeeper, actually, where do they want it located? So for us, we literally just make its own category within payroll of childcare bonus. And you can actually, so you can do that. Or if you want, you can actually pay the childcare place.
And then you write it off. That's what I was going to say.
Yeah. So you can do either. It depends on what your taxes are in your state too, how they tax bonuses. So that's either that or just write the check to the daycare directly. But, the point being, looking at alternative ways for them to find value, I think is really important to attracting doctors. Compensation wise, I've heard anywhere between 25 and 35% collections. The reason some doctors, by the way, for people who are listening, sometimes say net production is just because doctors sometimes feel that collections really are out of their control. And so they sometimes want to work at an office that does net production. Collections makes beautiful sense because you can't pay out what you never collected in the first place. So it's nice for them to actually have some sense of ownership in that process as well of the actual collections. So I've seen it all. I've seen sometimes people charge nothing for labs. I do have them pay 30% of their labs after a certain point, just so that they do care about what labs they use and they at least have their eye on the costs. And then, from there, I think benefit-wise, it's kind of all over the board as to what people can offer, based on regionally where they're at. So.
Yeah, and I know DSN, we've had previous really good discussions on CE and how to get more expensive CE paid for the associates and everything. And so those are brilliant discussions too. I had an associate that wanted to take some more expensive CE and we ended up doing it on me paying it as a deduction and then taking out of his collections. And so we wrote that out very carefully. But then I've also heard Mark where he says, okay, but we're going to write up a contract and there's going to be an ROI on this and you're going to stay for so long and I'll pay for the CE. So I think that there's some really awesome brainstorming ways that you can get recruit and keep and retain and actually improve your clinical skills for your associate doctors.
Absolutely. And getting them in a lane that they enjoy. So, they really love they really love endo or they really love whatever. It really, is that internal motivation for them as well as bringing huge value to the patients and to your practice. So I too, Kelly, have heard, I had a doctor that wanted to take an extremely expensive implant class. I did do the contract where I just made it amortized over 24 months. And if she leaves within that amount of time, it's per month how much she would owe times the amount of months that she left prematurely. So yeah, there's smart ways. One doctor, I actually had him put 4,000 of it on his own credit card, and then I paid the rest, so that he did have to have some buy-in with it as well, because I do think that's important. I think that, you know, bigger perceived value when they have to pay sometimes. So all over the board for that as well, for sure. But yeah, I'm just trying to think too, you know, Ashley, well, and everybody, questions that we all tend to get is usually, do I need an associate? How do I find one? How do I onboard one successfully? Retaining them, you know, we kind of discussed hiring the right fit helps from the get-go. One thing we didn't real quick touch on was sometimes finding out personality test-wise, like a Colby or something like that. You know, it's really important to know kind of what kind of personality do they have. If they're a huge entrepreneur, they may hang out in a year or two. And then I'm trying to think, you know, benefit package-wise, we talked about that. Anything else that we kind of didn't touch on, Ashley, that you can think of?
I love your idea of offering things outside of the box. That's something I hadn't heard before, and I think that's incredible and something that can go a long way. Like you said, like $2,000 for the year would have cost you less than health insurance would or whatever. I know I can't think of anything else really, but I love these outside the box ideas, and I think that's something to consider as well, is, you know, what are those things that they might be looking for, and trying to understand, Kelly, like you said, exactly what their motivation is, right? Like it's kind of like the 5 love languages thing, like what motivates people. Sometimes it's not money, sometimes it is money, sometimes, or gifts, you know, whatever it might be. So kind of I think that's why personality testing and that type of thing is really important, because it can help you in managing that person to help them be their best. You know, it's not just like, how can I have control over this person? It's how can I help them be, you know, succeed the best in this role as well.
Absolutely. Yeah, that's so good. Well, thank you, ladies, so much. I hope that, you know, people got to learn from all of the things that I think we've all here done well, and the things that maybe we didn't do quite as well as we wish we would have. Hopefully people got to learn from that. So thank you so much for giving your time. I'm so grateful to both of you. You guys are just good friends, and like just such great, you know, entrepreneurs and owners of your practices. So I'm grateful for your time. I know how valuable it is.
Yeah, thank you. Right back at you.
Yes, thank you.
Thank you,
Ashley. As always, thank you very much for everything. Thank you for contributing every time too. So, all right, Ashley, is there a code or anything that usually
not on this one, no code on this one actually, but yes, thank you guys so much, and until the next Lady Leader series.
Thanks, guys. Bye.
Thanks.
All right, bye-bye.